Kristen Go. I'm the editor-in-chief of CalMatters. Next to me, we have Ann Bakar. Ann's the president and CEO of Telecare Corporation and a board member here at the Steinberg Institute. Telecare serves 32,000 people a year and operates in 5 different states and is the largest provider in California. Next to her is Veronica Kelley. She's the agency director of Orange County's healthcare agency. She has more than 30 years of experience, you just must be a child when you started, in the field of behavioral health and has been a licensed clinical social worker for nearly 25 years. And next to her is Robynne Rose-Haymer. Robynne is the vice president at Capital Impact here in Sacramento. And she spent several years working with nonprofit organizations to serve low-income families and communities of color. And she was a member of the Benioff Housing and Homelessness Initiative. Like the last panel, I would like for us to start by being grounded in a personal experience, because I think that helps us bring some of the compassion that Daryl was talking about. So Robynne, I'm wondering if you could share with us a little bit about your story, your personal story.
I'd be happy to. My first experience of homelessness was actually when I was a teen. I was a teen parent, and my mom was a school teacher. And I don't know if you know anything about K-12 education in California, but teachers don't get paid very much. And so when I surreptitiously added an additional member to our family, it really put a large strain on our household. And so I moved into what I now know is called a host home, but before it was just one of my mama's friends. And during that time, my mom and my sister lived someplace else with another relative, and I lived with a friend, with my daughter. And one of the things that experience gave to me in my very early life was the importance of relationships and your network. Because I didn't experience unsheltered homelessness as a result of losing our housing. I had the great privilege and blessing of being welcomed into a home with a family that I was familiar with. And that is really an important moral of the story as we talk about people experiencing homelessness. Because oftentimes the untutored say, well, we've got shelter beds available. Why don't people just move into them? And I often remind people that the folks who you are expecting to just pick up everything that they have and leave everyone that they know don't know those people. They don't know if those people snore. They don't know if those people keep a clean house. They don't know them enough to want to share a bathroom with them. So there are some very basic premises of humanity that we forget when we expect people who are experiencing unsheltered homelessness to just move in with strangers. So since then, I've had the great pleasure of only experiencing homelessness one other time, and that was during the mortgage crisis. Because as previously mentioned in several panels, structural racism plays a huge role in financial viability, particularly in our great state. And so we lost our home and, again, had to go out into my network to be able to house myself and my children. So it is with deep introspection that I believe that networks, relationships, and trust are really important hallmarks of this conversation.
Thank you for sharing those stories. That it's really important to be able to hear from somebody who's had that experience and the vulnerability that you shared with us. I think that's very helpful for this room. I'm curious, from your perspective, how has that helped your approach to care and the work that you do?
Well, first of all, perspective is everything. So if you are operating from a framework as a decision maker or someone who runs a program and you don't have personal experience, then you need to get you a lived expert immediately. And the reason for that is because your perception of what might be appropriate or necessary for individuals who need your assistance is probably not as right as you think it is. Also, it's very important to remember that people most proximate to a problem typically have the best solutions to it. And so really it's kind of a hack to get someone who has lived expertise in your sphere, because those folks can give you really authentic advice about whether or not the remediation you're proposing is going to have any viability.
Thank you. And you took over your family business, and your business has operated here and elsewhere. And I'm curious, from your perspective, what have you seen change for the better and worse over the years when you're looking at dealing with behavioral health issues?
Wow, that's a big question. Yeah, my father, who had mental illness in his family in 1965, partnered with a psychiatrist and created what was the first freestanding psychiatric hospital at that time in the Bay Area. And it was sort of the time of One Flew Over the Cuckoo's Nest, right? So he had this vision of hope, creating a home-like environment. There was a Chronicle newspaper article, "This is a hospital." So he had a very hopeful vision for creating a different approach that was more recovery-oriented. They didn't use that language at that time, more home-like, where the culture was part of the intervention. And he ran the hospital until 1987, and then he died unexpectedly at that time, which was, I'm embarrassed to say how long ago it was. It was 37 years ago, right? And I stepped in at that time. I never expected to. And so we've gone from 5 programs then to now we have about 175 programs in 35 counties in 5 states. And I often think about it, my personal story, I'll get into sort of the field, but it really was like raising another child for me. I mean, it really has been a work of love. I was very close to my father. A rabbi said to me recently, it's almost like I've been saying Kaddish for my father for 37 years. I never thought about it that way, but I feel like it's been a work of love, a way of enlarging his spirit and carrying on his mission, as well as having a very significant purpose and impact in the world, which I think our 5,000 employees really feel at Telecare, that they are making a huge difference, which they are. In terms of the field changing, I mean, I'm working on an oral history right now at the Bancroft Library in Berkeley. I think, interestingly enough, I would say that the Mental Health Services Act, Prop 63, which Daryl Steinberg was the architect of, had probably the most seismic effect in California of anything. Where's Daryl? I just want to acknowledge him. And everyone involved that I've seen, because before that time, the focus really was more on institutional care. And I think the Mental Health Services Act created really what is now the FSP model, which is the Madison, Wisconsin Act Assertive Community Treatment Model, which is probably the most researched and effective program model that there is for people with serious mental illness, and disseminated that across the entire state in a way that has been foundational to the development of the community mental health system. And it also, I'm looking at Karen and others, it also had outcomes attached to it that we're still trying to collect, but the idea that we could impact hospitalization, incarceration, and homelessness, which we know we have, and it had a recovery framework that at Telecare, I mean, I would just agree, at the end of the day, it's all about relationships. If we have people going out and they're not connecting and holding hope for others and really engaging in a way that restores a sense of promise, helps someone develop their own sense of promise for their lives, we're not going to be effective. So I think the recovery model as a foundation has also just been a critical development, and now we have Prop 1, which is another iteration of that, and housing, and I think we're kind of at another tipping point in the state where hopefully the federal government doesn't undo it. But I think housing development, the specialization of services and the serving people that are in the I was going to say criminal justice system, but I guess we call it the criminal, some others says it, but I think this is a moment, actually, where there is tremendous opportunity to continue to move the system forward. Thank you.
Since you brought it up, you talked about the federal government not done doing anything. I'm wondering if any of you would want to take that on in terms of what some of your concerns might be.
I'm happy to answer that question. Maybe hold on to your seats, though. I think my current work is with the California State Legislature. Our firm runs a professional development program, and so we've kept a pretty keen eye on some of the impacts. And I will say that we were on an experiential learning trip in November, the day after the election, and so many legislative staff who were with us were like, oh, we're going to be fine. We have no problem. And then 3 months later, there was literally like screaming in the halls and people ripping their hair out because they really began to understand the tremendous impact of executive orders and other kinds of Project 2025 and all of the other writing that was literally on the wall and on the web and in your inbox and all of those things it was actually true. And so now we're dealing with like triage and recovery. Like, how do we mitigate those impacts such that it doesn't totally destroy all of the utopia that was being built here in California? So I think that there's a really hopeful message in that so many people are working in tandem to be able to ascertain the actual effects, but also simultaneously an appropriate amount of worry, in that what we've done is kind of turned ourselves over to people who really don't care about people and have the really deep ability to do massive amounts of harm to those folks who have already suffered so much trauma.
Veronica, is there anything you would like to add? I see you shaking your head.
I wish I were as optimistic as you, Robynne. So I think that we are looking at the dismantling of an entire behavioral health system that this state has worked really hard. We don't get it right all the time, but we have crafted something. And I also think it's incumbent upon us to not let this crisis go to waste. And it is our chance to reconfigure our system in a way that makes sense to the people who are receiving the services and the people who are delivering the services. And, you know, it's not that much shade on our legislators or people who are policymakers, but well-meaning ideas don't often hit the ground in the way that they're thought of. And so unless you include the people who are receiving the services, their families, and the people providing the service, we're left with a system that is kind of like as my friend DeWan in the back talks about, the Winchester Mystery House. It doesn't make any sense. And so that's really what our system is like. So I think that terrible things are happening now, but I think there is an opportunity for us.
You know, you've talked about some of the progress that has been made. I want to let you talk a little bit about some of the progress you've seen in Orange County. You know, you saw a reduction in homelessness among people with serious mental illnesses, and I'm curious, what did you find effective? Because that is something that all communities are struggling with at this point in time.
So I wish I could say we've remained having a reduction in homelessness, which we have not, like all of our counties. But I think we all come to the table and play together, and we don't like it, but we do it. And that's the only way. Many of our panelists talked about leveraging resources. We have got to do that. We've got to do that. I think the idea that we've been working since 2005, county behavioral health and many providers, including Anne, our partner from Telecare, we've been working on our full service partnership. And we haven't gotten it right from the beginning. We've been doing a lot of different things, but we work with the people that we serve, and we ask them, what do you need in a full service partnership? What are we not getting right? We talk to their families, we talk to our providers, we talk to the state. And so we've crafted a really great model. It's not magic. And I think everyone's looking for magic. There ain't no magic here. It is a good model, that if amazing people who are dedicated to this mission to serve others and not worrying about getting credit for it, I think that's what's created the magic in the full service partnership, such that Orange County, we have 16 full service partnerships, and in fact, unfortunately with Prop 1, I got to cut a few because I don't have enough money in my FSP bucket to support that, which is devastating to us and to the people we serve. But 16, our most recent is the Care Court full service partnership. We have 4 FSPs for people who are unhoused. One of those is for people who are 60 plus years old. They're all filled to capacity. And in a full service partnership, while we do have brick and mortar, that's not the goal. The goal is you have a case manager, you have a team, and they go to you wherever you are, wherever you live, in an encampment, in your mom's house, wherever it is. We do that. It's 24/7. And all of our FSPs have housing attached to them. However, again, this isn't magic. Just because you have a house doesn't mean it's magical. People have to want that. And since our folks, the people that we are working with, have been so traumatized, oftentimes by our system and us, they are not that willing immediately to come into 4 walls and shut a door behind them. And so what we found I was also the director in San Bernardino County for 6 years, and what we found there, using MHSA dollars and Innovations Project, is that on average, an unhoused person needs 40 interactions, not just a, hey man, how's it going, but I'll buy you coffee at Carl's Jr., we'll sit down in silence, but I'm here. 40 of those. And after that, 90% of those folks activated voluntarily into treatment, because people know what they want, and we have to listen to what they want and then eventually help get them to what they need.
That's a lot of different interactions. Yeah. Robynne, I'm curious, with the work that you do, what are some of the ways in which you have been able to effectively work with the different communities that you've served?
Absolutely, and I so appreciate your answer, because the reality is systems by design have dehumanized individuals. Those people don't deserve our money, or those people are built for, this is what they want. They want to live out there. And I think that one of the best things that the 40 interactions process does is it really humanizes people. You don't spend 40 iterations of your time with someone if you don't see them as a person. And so humanizing individuals is the very first thing I think that is effective. One of the most powerful things that a young person experiencing homelessness told me was that they always knew that they were going to be okay when someone walked by them as if they didn't make eye contact, because that means that someone didn't see them, they weren't observed. And that shocked me, because I don't like that. When I walk by people, I want them to look me in the eye and say hello. And then I thought about it more, and I thought about my behavior when I walked by people experiencing homelessness. And I thought that when I walk by people and I don't make eye contact, that's a me thing, not a them thing. Like, I'm embarrassed that I haven't done anything more to help remediate their situation. And so I think it's important that when we're creating programs, we are involving, first of all, people who are going through the experience so that we have some good feedback about the program. But I also think that understanding what an individual wants, and realizing it's very hard to build huge systems one person at a time. But if you're looking for an individual program to meet with effectiveness and efficacy, the way that you do that is by individually meeting people where they are. Sometimes that's Carl's Jr. for coffee. Sometimes that's an encampment. And eventually it might be your office. But anyone who works in the system who thinks that this work is behind a desk or behind a glass wall probably should go get a job at Bank of America, because that's about the only place you're going to be able to sit all day behind a glass wall and be effective. So I think that workforce training plays a huge role in a program's ability to be successful, particularly since so many people who work in both behavioral health and homelessness workforce are people with lived experience. So they're experiencing secondary trauma. By working with people, they're experiencing vicarious trauma. And so making sure that those workforce arenas are places that are safe for folks to work. And I'm also going to say something that many providers probably won't like, but you got to pay people a livable wage to keep coming back to work. Do you know how much eggs are? My goodness. So it's important to make sure that you are creating an environment where people are able to work successfully and still maintain their households and be able to serve the people that are coming to your business.
One of the things that Robynne and Veronica, you mentioned was, the effectiveness of some of the working with full service providers. And that's the space that you know well. I'm curious, from your perspective, what are some of the biggest challenges that you face as a full service provider?
Mm-hmm. Well, I had some things on my list, but for some reason, as we're talking, I was going to add to it. I don't know if everyone knows, full service partnerships have some critical elements that have made them successful. This is the single point of accountability for people with serious mental illness, the team, a multidisciplinary team of workers. They're available 24/7 around the clock, which has made it unique. They do whatever it takes. So it's not a program that people come to. It's a service that is delivered where the person is. It's wrapped around the person. And historically, it was actually lifetime membership. So there was this continuity of care from the team that was very important, which of course in most places and in California has now had to change because we have so much need. So there's tiered services and other ways that people are now discharged. I would say one of the biggest issues that we see with full service partnerships, first of all, it works. We can talk about outcomes all day long. We need better outcomes, we need better outcomes. We know it works. It's between a 70% and an 80% reduction in hospitalization, incarceration, and homeless. We did a 4-year study, a Pay for Success, Stanford studied it with Santa Clara County. We know in a controlled environment we get those outcomes. So I think outcomes are okay. I mean, we need better outcomes, but we need more FSPs is what we really need. And we need different types of FSPs because there is in the BH Connect waiver now this requirement for full fidelity. What we've seen is full fidelity doesn't necessarily generate a different outcome. And so we think saddling counties with full fidelity act is not going to help, but allowing counties to have resources to provide an array of different types of FSP, maybe full fidelity case management would be a great service. So I think more ACT FSP type services with flexibility would be very, very helpful. I think another...
What's preventing that?
What's preventing that? I will turn to my partner. I think, there's a funding issue. There's a standards issue. I think one of the other things would be county to county. There really isn't standardized FSP criteria, both in terms of the rate setting methodology as well as in terms of what are the essential elements. Would you elaborate on that?
No, but I would agree.
Okay,
Yeah,
so
that's
CalAIM, ironically, CalAIM, the promise is, to have more standardization, but with FSPs, we don't have as much standardization around rate setting, for example, which would be extremely helpful. And that precludes providers like Telecare from providing FSP services in some places. So those are real issues. I think housing is a huge element that will enhance the viability and success of FSPs and allow transitions. That would be more helpful. With the Prop 1, we were a big advocate to have the housing that's going to become available be available for people in FSPs. It wasn't actually in the legislation, but I think we've been advocating, and counties are kind of, taking up that baton. But if there was one thing today, I've been an advocate on the Steinberg Institute for these type of symposiums. I do think creating more dialogue with the state around what we can do to enhance your question, the viability of FSPs as the backbone of our community mental health system. Having more dialogue with the state would be, so it's not the Winchester Mystery House. There's clarity and communication around what we can do together would be a huge outcome of this panel, actually, I think, because there is not as much clarity and dialogue as there needs to be around some core elements beyond outcomes.
Veronica, is there anything
I would
else you'd
just
like to
say
add?
that yes. I think we are all partners in this. And you take a model that we know works, we have proof that it works, it's efficacious, it's better in the long run. The people we serve tell us that. It's not just about we've reduced, and in Orange County it's reducing, people in FSPs have, 90% of the people in FSPs do not go in inpatient hospitalization. That's pretty significant. 96 do not go into jail. 80% remain housed. So those are great. We know how to do that. We and the providers know how to do that. The people that we serve know what the magic sauce is there. And the counties know, because we are required to, we've been doing this for a little bit. So it would be great to have more open dialogue, as Ann said, with the state, so that they could ask us before they make a change. Before they make a regulation that says you're gonna do these kind of tiers, you know what? Ask us. We can tell you if that's gonna work. Because at the end of the day, oftentimes it doesn't work. And the people who pay for that are the people we are trying to serve.
One other, I'm sorry to interrupt, but CalAIM may have unnecessarily provided disincentives for things that are critical in ACT services and FSP services, such as outreach and engagement. In a county like LA, we are not reimbursed. Our staff can't bill for travel time, for example. It's a really big county. And so LA County, and that's where the partnership is so key, actually stepped up and provided an additional resource for outreach and engagement funding. But it would be better if the new rates, if there was an adjustment in CalAIM so that kind of activity could be reimbursed as part of the process. Because a lot of times people with the most severe mental illness and homelessness, you do have to make multiple attempts to find them. It's not as clear where they are, and you want staff to go wherever they have to go. And so if that's not something that is allowed in the billing system, then it precludes that kind of activity unintentionally.
Couple threads that you guys mentioned that I want to pull on a little bit more. Okay. You mentioned, housing is needed. Prop 1 is supposed to provide 4,350 units for supportive housing. In 2018, No Place Like Home was supposed to provide 20,000 units of new permanent supportive housing. I'm going to call out Jocelyn, who is one of the CalMatters reporters, who said that we did a story looking at actually only 1,797 units have been built from No Place Like Home versus the 20,000. And you guys are talking about money that needs to go into housing, money that needs to go into some solutions. And I'm not saying that housing isn't a solution, but I think there's also a little bit of an issue in terms of accountability of how that money is spent. Mm-hmm. And also county by county. How things are done different county by county. Is that a helpful or hurtful thing when we're talking about making a difference in behavioral health and homelessness?
Is what a helpful thing?
County by county solutions.
Well, I would say, having been a behavioral health director in two large counties, that before everyone rolls their eyes about, if you've seen one county, you've seen one county. Seriously, if you've seen one county, you have seen one county. Calaveras County is very different than Los Angeles County. They have different, thank you, small rural counties. They have very different needs. They have a different population. They have different providers in that population, and they have different resources. So, and I've been in two large counties. The largest county in the United States, San Bernardino County, 21,000 square miles that we have time and distance standards to get to. Got an hour to get there. Yeah, good luck with that, across all of our desert. A population of 2.1 million people. Orange County, 790 square miles, 3.2 million people. Same budget. Totally different problems. In San Bernardino County, if I were in the upper part of the county and I were at the river and I had a psychiatric emergency, Dr. Insel knows this very well, I've told him about these things and he's actually driven out there with us to see part of this, but if I were out in Needles, California, population 6,000, not a grocery store in the town, it's a food for a 99-cent store, no grocery store. Half of the population is on Medi-Cal. If I have a psychiatric emergency there, I'm in a car, and the county, we have an office there. If we were to put someone who's a danger to themselves on a hold, they're driving in a car with me for 4 hours. 4 hours without traffic, so let's hope there's no traffic, in order to get to the closest psychiatric hospital. 4 hours. Now in Orange County, we complain, but I can get to a psychiatric hospital in 20 minutes on a Friday. That would be easy. Very, very different needs. We cannot, standards are great, but there has to be flexibility. And thinking too, because we've talked about workforce, in San Bernardino County, in the area where Needles is, Barstow, Victorville, we couldn't find an RN, not one. We had to change our whole program so we could use a licensed psychiatric technician, an LPT, to dispense medication, because there were no RNs. Those are things that are county by county. And regional models work in many places, and in many places they don't. SoCal would never do well with the regional model. We're too different. There's no way that we would. And it's not because we're all difficult, like Dr. Sharon over there, but we have very different issues. And again, just one more thing, we are locally controlled. So it's great that the governor says these things from over here on high, but you get to my board of supervisors, means nothing. Means nothing. I can't imagine what it means in Nevada County or Calaveras County. In the northern states, I can't imagine. So that is essential for us to remember. We have to have flexibility. Standards, accountability, absolutely. But if we don't have the flexibility, we will remain at this place where we're all struggling to provide good care.
Should counties have the same standards and accountability though?
Maybe by size, and we do have that. Smaller counties have different things, medium size and large, and LA's out by themselves, but yeah.
I think there's certain things where you'd probably get everybody to raise their hand and say, do it. Like, whoever came up with the idea of letting every county have their own EHR? Like, where did that come from? Bad idea. Bad idea. I'm looking at Tom Insel. And then you want to know why we can't get outcomes, because every county now, it's like there's another one. There's like every county's got their own EHR. Bad idea. Should have been standardized. And then they have an accountability commission to get data that we could never get because everybody's got a different EHR. So I think there's certain things that, it's time to say, we've got to change this. We've got to have data that we can share. I mean, that's really, really essential. And then there's other things that you shouldn't try to say every county has an FSP program that follows, in my opinion, this fidelity model. I think in terms of defining specifically how the delivery system is developed, but the methodology for setting a rate, yeah, we should have the same methodology for setting rates. So I think it's not a yes or no answer. I would say operating in other states, we've had really unfortunate experiences operating in states like, I'll say Arizona. It seems like every 2 or 3 years they have a new Medicaid managed care company that comes in and, runs the system with great promise, and then they're gone and the whole system gets changed again. And it's a great political maneuver for the governor, because then he doesn't have to be accountable. It's just the managed care company. So I know that there is advocacy for that kind of thing in California, but our experience, I probably just got myself in trouble in Arizona. I don't know the current governor, but I think
There was an earlier pro-Arizona
oh my
comment on
God!
a different panel.
Just look
It's
up
okay.
how many times has Arizona changed their Medicaid Advantage shares. Just look it up. You know, it's a small program we have there, so I'm not too worried. But anyway, I do think it's a popular idea because it sounds simple to just have somebody come in and centralize everything, but I think it's dangerous.
You, like you said, you work in 5 other states. Are there things that California should be taking from other states that handle behavioral health and homelessness better than California?
The thing that, first of all, I really think California does better than it gives itself credit for. I mean, California, a lot of states, it took them, how long did it take them to accept Medicaid expansion? I mean, come on, Medicaid expansion, and then we have the Mental Health Services Act and realignment on top of it. So when you look at the generosity of funding in the state of California compared to most states, I think, and then the requirement for an evidence-based practice like FSPs, I think California has a lot of headway that needs to be acknowledged and held. I've been very, very frustrated by the workforce inability to get access to workforce grants and funding in California. You know, we as a provider can't apply for any of the HACI funds that are coming out. We can't have a program apply. It has to be each and every individual apply. And in Washington and Oregon, it's been a much different process and much easier for us to get bonuses and additional funding at critical times. So I would say the approach to workforce has been preferable.
I'm curious, this governor has made homelessness a priority, but in this most recent budget, he has not increased the amount for homeless services. Can each of you share what that means for you and your work?
Well, I'll go first. I will say that when you identify that there is a problem and you dedicate resources to that problem, and then you wake up the next day and say, you know what, never mind. It does send a bit of a mixed message. And I'm being glib, but I will tell you that the people who are served by programs rely on consistency. They don't have nearly the resources emotionally, psychologically, technically to go run out and find the next funded thing. They are reliant in communities across the state that they can go to this place and receive this service. You know, the e-blasts that we get and the listservs that we're on and all of the notifications that we receive about new programming, that's like a professional person thing. And so your average everyday program user is deeply damaged when programs are ramped down. Staff are damaged when programs are ramped down. Then they're running around looking for the next place to find a job. You've got program partners that are jockeying over staff. It doesn't make for a good program community. And when people are dependent on those services, whether it's intended to be a long-term iteration of commitment or they're telling their network about the service that helped them, that then their network person goes and that thing doesn't exist anymore, it erodes trust. And all of us are out here purveying our services on trust. Whether you believe it or not, that is the case. People vote with their feet. So if, in fact, we are eroding trust and it gets out into the community that this service or this program is no longer available, it takes a long time to get that back. It takes more than those 40 iterations of communication to get it back because you've already proven yourself to be unworthy. So that was a very long answer to say it's probably not a good idea.
Veronica?
I would say the same thing. Without the funds that are not going to be moving forward, we're not going to be able to address homelessness in our county, period. But it is, I think, to put it kind of bluntly, to put our money where the governor's mouth is would be very helpful. That these are our taxpayer dollars. We need to put them where the issue is. And that doesn't mean that we just create more vouchers and more shelters. It means that we address why does it cost $600,000 a door in Orange County to build an apartment? $600,000. Why is the cost of rent so high? We can't, many of us in this room can't afford a mortgage. We can't afford our rent. In Orange County, a studio is $2,300. And if I have a client who has SSI, that's $900. How can they live in an apartment? They can't. Even if we subsidize that, they can't. They can't afford food. And then we get upset with them, well, why aren't you eating? I mean, it's ridiculous. So it is not just one part. It's not just about building these very specific kinds of homes. It is this whole cultural shift. This from NIMBY to YIMBY, which is yes, in my backyard. It is our community, but that's hard because that means we all have to change. Our culture, our belief, all of that has to change, and we are the problem. If I'm honest, we are the problem. It's all of us. We say it. Oh my God, we don't want to see those poor people on the streets. But if they're going to be moving into my neighborhood, well, no way. Let's go put them over there, and in the unincorporated areas. So we either lean all the way in to these social issues or we don't. And we just, at least, we can be honest about it.
That's right.
Ann?
I think, I'm not sure I understood the question. I think it's, homeless services, how are we going to address, I was looking at the numbers. I think there's 173,000 homeless people in the state of California. 123,000 who are unsheltered. I was adding up No Place Like Home, Project Turnkey, the other initiatives. I think it adds up to about maybe 45,000 units. So you have 125, 130,000 homeless people, and you've got, with all these initiatives that aren't going up very fast at all, you have, maybe 25% or a third addressed if the units go up. So I think it is I agree. We need a completely different way of thinking about this. I know in LA County, Janice Hahn is thinking about turning the building on the grounds of the state hospital, a completely different, approach to building and development. I know Alameda County's been looking at some things as well. So maybe you use more public land. You don't get around the entitlement process. I don't know what kind of flexibility that gives you, but there is I think expecting everybody to change and open up their neighborhoods is not gonna happen.
That hasn't worked well so far.
It is our problem, but I think realistically it's going the other way. People are like, move them into jails. So if we're just brutally honest, we're gonna have to come up with another way to provide inexpensive shelter for people.
One last question for us to end on. This is a very informed and influential group. And I think we had talked also about, are there things that can come out of this? So if there's one thing that you would want done that could help the problem, that could improve the outcomes for behavioral health and homelessness, what would that be?
I'd like another panel like this with the decision makers from the state and the county and the policymakers sitting down and really having a hands-on session to work some of this stuff out so we maximize the use of the resources that we have and get more aligned.
I mean, along those lines, if we were to have another such convening, having our developers and the finance folks and the builders come to the table, because we talk to them off on the side and make our little deals, but having them be part of this, they're part of the solution too.
I'm voting on Dr. Shim's resolution of dismantling systematic racism. That's my vote. Honestly, I think I've been remiss in not mentioning the deeply important necessity of culturally responsive care. And that does, to some way, get at the heart of the issue of racism. Making sure, and in the HCI presentation earlier, they talked about the importance of an integrated workforce that reflects the state. I think that also gets at the problem. But I think ultimately, I want to go back to what Veronica just said, and let's be honest with ourselves. I'm not at your house at the dead of the night when you are talking to whomever it is that you talk to, whether it be yourself or your savior or your partner. But I think it's time for us, particularly in this room, to be honest with ourselves. And if you want to do this, you can't stand on your position or your paycheck. You have to stand on your values. And we got to be tired of seeing people who are experiencing homelessness and then going to work and saying, we care about those people. Do the thing you said you care about. I don't mean to call you out. I'm a very nice person most of the time, but I just want to take this opportunity while somebody has put a microphone in my hand to say the thing that is really the most deeply important to me, and that is, don't be scared to make the right decision. That's it.
That is a great way to end this panel. Thanks to each of you for sharing your personal insights and values. And I think we have a new agenda for next year for the Steinberg Institute. So I hope you guys were taking notes for the next few panels.
Thank you.